Okay, now it's recording. Okay, so hi everyone. So I'm Therese Stignoso, second year at the Hawaii CHC, and I'm the president for MSPA. I just want to say thank you for being here and taking the next step in supporting your future LGBTQ plus patients. Just two things to say. We're still looking for a first year liaison, so message me if you're interested. You don't have to be queer to apply. And two, just something to keep in mind during this workshop. So Art graciously shared this article on our Facebook page. Basically, the Trevor Project did a LGBTQ youth mental health survey this year and estimated that about 40% of LGBTQ youth seriously considered suicide in the past year. And that number is more than half if they identify as transgender or non-binary. And one way to support LGBTQ youth is to affirm their gender identity. And that action alone is consistently associated with lower rates of suicide attempts. So please take today's lesson seriously and use it in your future practice to save lives. Now, with that said, I'll do a quick introduction to our guest speaker today. Lindsay Morrison, she has a master's in health administration, pronouns she, hers. She is also a process architect at Keck Medicine of USC and is also the creator and chair of Keck Pride Committee. She helps design and implement strategies to foster a welcoming environment for LGBT patients, families, and employees. She has successfully led the effort for all USC hospitals to achieve the Leader in LGBTQ Health Equality designation for 4 years and has provided close to 1,000 hours of LGBTQ cultural competency training through the health system. So without further ado, Lindsay Morrison.
Perfect. Thank you so much for that introduction. I'm so excited to be doing this. So we have a lot to talk about in the next hour. We'll have the PDF available of the presentation to send out, and it's also recorded so you can reference in the future. Again, we kind of went over the logistics at the very beginning, but again, you can please keep yourself on mute. I strongly encourage adding your pronouns to your username for this session and any other Zoom sessions in the future, and then we will have some time at the end for questions. But you can also drop anything in the chat at any time. So like Therese said, I'm the creator and chair of Keck Pride Committee at Keck Medicine of USC. So we are an academic health system, center and health system located in Los Angeles. We have 3 hospitals. So we have Keck Hospital, which is our surgical hospital. So it's tertiary quaternary care. We don't have an ER. We don't deliver babies. But that's my primary work site. We have our cancer hospital. And then we have USC Verdugo Hills, which is our community hospital, has an ER, has labor and delivery. So over the past 4 years, 5 years, really been working to make sure that we're implementing best practices, looking at our gaps, looking at our opportunities. And like she said, as part of applying and working with the Healthcare Equality Index, I've created this training that's approved by them to meet their cultural competency needs and expectations. And I've given this presentation provided over 1,000 hours of training over the past 4 years. So this is something I love talking about, so I'm gonna dive right in. That's a picture of us at the LA Pride Parade last year, back when we could all gather in person and be around other people. So it makes me very nostalgic to look at it. So we'll go through terms and definitions for sexual orientation and gender identity. Again, I don't want to assume anyone's knowledge level. So some of this might be familiar, some might be unfamiliar, but we'll just make sure that everybody's on the same page. I'll talk a little bit about healthcare discrimination and how that impacts LGBTQ health disparities. But I really want to spend the bulk of the time talking about what we can do. What are these strategies and resources to create that welcoming environment? So terms and definitions. First of all, I always start these off by asking the question, right? Like, why are we talking about sexual orientation and gender identity? And it's really because everybody has a sexual orientation and a gender identity, right? It's not something that only a small percentage of the population has. And I'm actually not going to spend a ton of time going into like, this means that this means this, because the terminology really varies. So I've been giving trainings and talks about the LGBTQ experience for about 20 years now. And so some of the terms that I was using back in 1999, 2000 are different. They're more outdated, so I'm not using them anymore. So it's important to kind of know the time period you're talking about, the context that people are using, you know, the terms like what people are talking about with their friends are not necessarily going to be the same words that they're using with their doctor, and who's using them, right? Like the comfort that they have with those terms. So really it's all about creating that space for your patients to tell you who they are. That's what's most important, to be able to deliver that personalized, compassionate care that we talk so much about in healthcare, right? So as we go through, just keep in mind, especially because, you know, it's lumped together a lot. We talk about sexual orientation and gender identity together, but they're two separate and very distinct things that are actually not related to each other. So sexual orientation is just all of those ways that we're attracted to other people, right? It's who you're attracted to, who you fall in love with, who gives you those like tingly butterfly feelings, which is separate and different from your gender identity. So that's your personal internal sense of your own gender, right? So it's feeling like a man, feeling like a woman, not identifying with either of those distinct boxes, which we will get into. So just keep those in mind as we move through this. I don't spend a lot of time on sexual orientation because I also feel like in 2020, again, maybe this is an assumption, but like most people are more familiar with sexual orientation terms by this time. So I'm not going to go through and read every single one of these, but I do want to make a special note for bisexual, is that it's not about being attracted to men and women. It's about being attracted to somebody of the same and or other gender than yourself. So just kind of keeping that in mind. And when we think about sexual orientation, especially when we're working with patients or other people, thinking of it in 3 dimensions. So there's the identity dimension, right? And that's the label that you use. That's the term that you're comfortable with, how you refer to your own sexual orientation, right? So these are the terms that we see: gay, lesbian, bisexual, straight. Again, like Santa's list of terms, right? It can be as individual as the person is, but it's the term that somebody uses. Then, of course, there's what you're actually doing with other people or not doing. And again, I assume most of you know what behavior looks like, you know? So it's all of the different things and ways that you can express that with others. And then, of course, there's your attraction, you know, again, like who you're attracted to, like who creates those feelings. And so for myself, you know, the example is I'm capable of being attracted to and falling in love with people of all genders. So for a lot of people, these 3 dimensions are one single circle. You know, there's no difference between the term, the behavior, and the attraction. But for others, it can be very different. So again, not having an assumption of, okay, I know one piece of the puzzle, that means I can infer what the rest of it looks like. That's not always the case. So again, creating that space for people to tell you. And that leads into this, is that, again, just because you know a piece of that puzzle, so knowing somebody's sexual behavior, their sexual history, the term that they use, it doesn't mean you can assume how they will self-identify, right? So if you're talking to somebody and they're saying, oh, you know, I'm a man, I'm currently only having sexual experiences with other men right now, that doesn't mean that person is going to self-identify as gay. Again, if you're taking a sexual history or you're talking to somebody and you find out that they have past sexual experiences with men and women, again, doesn't necessarily mean that they're going to identify with the term bisexual. And then, you know, again, going back to these assumptions and how dangerous they are, a person could be married to, you know, an opposite gender partner, doesn't mean they're going to self-identify as straight. So to combat this, it's really important to ask the same sexual history questions or the same intake questions of everybody and get to know how they see themselves. And that's all I have to say about sexual orientation. Like now we're going into gender and gender identity, because I feel like that is something that is still not talked about as much. So before we even get to the concept of being transgender, right, we have to think about what it is we think of when we talk about gender. Because I feel like for most people, again, when you grow up, what we're taught is that someone's gender is what they were assigned at birth. You know, you're born, the doctor looks in between your legs, something goes on the birth certificate. That's your gender assignment. You know, you are not a part of that conversation. So for that reason, the most important component of gender is someone's gender identity. And again, that concept of that's your internal sense. So as you're growing up, as you're thinking about yourself, you have your own understanding of your gender. So not focusing as much on what was assigned to somebody, but focusing on their internal sense. And I think it's really important to talk about the gender binary too, especially getting into that idea of unpacking perhaps the messages that we learned growing up, because a lot of the times we think of things in a very binary way, and we think of sex and gender in a very binary way, you know, that there are only two options, they're kind of fixed, they have certain characteristics that go with them, and that's it. You know, so you're either female or male, man or woman, boy or girl, those are the two choices, and that's it. But that's not how nature works, right? That's not what we see in nature, and it's not what we see in people. So even when we're thinking of sex, like the physical characteristics, so somebody who's intersex, that's just a kind of umbrella term for a variety of conditions where someone has reproductive anatomy, sexual anatomy. It could also be chromosomes, hormones, etc., that just don't fit that typical binary definition of what we think of when we think of female or male. And then when we think about gender identity, somebody who's non-binary, their gender identity doesn't fit in that two boxes option. So no matter how we're looking at sex, gender, thinking about it, it's just not binary. That's not how we are, and that's not how we've ever been, because I think a lot of people also have this idea that, oh, this is kind of like a new trendy thing, like people identifying as non-binary, it's hip. But non-binary people, intersex people, been around since people have been around. And the United States actually is behind the curve. So there's several countries that grant legal recognition to people who are, again, not just M or F, those two binary options. I know everyone's kind of all over the place in this session. In California, Oregon, some other states, there's a legal designation of non-binary. So in California, where I am, you know, now this went into effect last year. So you can go to the DMV. I actually don't know the process now that we're in a global pandemic, but when it was implemented, you could go to the DMV and select X for your gender marker. So instead of just M or F, it's now M, F, or X. So again, like as a health system, we have to make sure that we are being inclusive and welcoming. So again, just kind of keeping that in mind. Had to get through all of that to talk about what it means to be transgender, because it's really just a broad umbrella term for people who have a gender identity that's different from what they were assigned at birth. So you'll hear it abbreviated as trans. I will probably say it abbreviated as trans. But the big takeaway here is to, when we're thinking of people, when we're referring to people by their gender identity, how they feel about themselves, and not focusing so much on the birth, sex, or genitals. You know, like that's not how we interact with people on a day-to-day basis. I'm not doing a pants check on somebody before I decide what pronouns I'm going to use or how I'm going to treat them. That's not how things work. And that's especially not how welcoming healthcare works. And of course, it's not just transgender and everybody else, right? So if trans means different than, cis means same. So transgender people, gender identity is different from what was assigned at birth. Cisgender people, gender identity and birth sex align or correspond. So again, that's the majority of the population. I feel like many people on this call, on this webinar, probably found a new identity term, so congratulations. And some different transgender identities. And the terms that I'm using on this slide are ones that you will find most often in electronic medical records or when you're doing literature review looking at research. So these are not end all be all, but these are the ones you'll see most often. So a transgender woman, so a woman who's trans, male to female trans woman. So she was assigned male at birth, identifies as a woman, and is going to take steps to transition and live her life as the woman that she is. So of course, trans man, transgender man, you'll see female to male, trans person or trans man. again, somebody who is assigned female at birth, identifies as a man, is going to take steps to transition and live as the man that he sees himself. And then, of course, those are two very binary identities. People who are non-binary, you might hear gender queer, gender fluid, gender non-conforming. Again, having that gender identity that falls outside of the gender binary. And I mentioned transition, and you know, it's not this linear path. It's this whole process of people, you know, recognizing their gender identity, affirming it, and sharing it with other people. So there's a lot of different components that I'm going to go over more in depth on the next slide. But I think the thing to keep in mind is that we have this popular narrative of, oh, this person is transgender. Have they had the surgery? Like there's this line that people have to cross in order to be authentic, official, anything like that idea. But there is no finish line, right? So everybody can do whatever feels best for them with the time and resources that they have. So keeping that in mind, that there's not this threshold that someone has to meet in order to be considered transgender. It's about their personal identity. And so general aspects of going through this transition process, you know, affirming one's gender, I think of the cardinal colors on the left as kind of the lower barrier, and that doesn't mean it's easy. It just means there's not as many structural barriers. So many people who are transgender, you know, they'll choose a name that better suits them. They'll wear clothes that reflects their gender identity, that expresses themselves, and they'll communicate this to other people, right? You know, please use my pronouns, please use my name. And so that's kind of the lower barrier to entry. But the legal and medical side of a transition, this really depends on where you live and what access you have. So that's why we can't put emphasis on these processes to respect and affirm someone's identity, right? So if possible, many trans people will change their legal documents, right? Having your driver's license updated, your passport, your birth certificate, all types of documents that reflect who you are. If you have access to medical care, pursuing hormone therapy, gender-affirming hormone therapy, and then of course, there's various medical and surgical procedures that people can pursue to better align their bodies with how they feel. But again, I really want to emphasize, some places it's illegal to do these things. You cannot change your legal documents. It's very difficult to find affirming healthcare, which we'll talk more about, and having access to insurance, having the financial means to cover these can be a very, very difficult barrier to cross. So when we're thinking about how are we affirming somebody in our healthcare practice, we really have to focus mostly on the personal and social side to make sure that people can let us know who they are. And so before we get out of this section, just really wrapping it up with, you know, LGBTQ is just an acronym that stands for lesbian, gay, bisexual, transgender, and you're seeing the Q more and more. So the Q stands for queer, sometimes queer questioning, but it can get confusing when we think about this population sometimes because we have to be very specific, right? Because lesbian, gay, bisexual, those are all sexual orientation terms. And then we take a hard pivot over to transgender, again, that gender identity umbrella term. And then the Q for queer is really like a bit of everything. Some people are very uncomfortable with the word queer. Of course, it has been used as a slur. It still is used as a slur. It can feel very offensive and uncomfortable to some people, especially people in the LGBT community. I love it. I think of it as like a big hug where everyone is welcome. You know, you don't have to identify with one of these other specific terms that's in the acronym. And of course, sometimes you'll see more and more now the plus. So again, a lot of other identities out there. We want to make sure that we're as inclusive and affirming as possible. So wrapping up this section with just some respectful language, because again, depending on how you're researching, what you're reading or hearing, you'll hear some of these terms and just keep in mind not to use them. So homosexual, you know, this is a very clinical term. It's very outdated now, and for a lot of people, it's very hurtful because it has very historical, very violent and pathological associations, right? You know, being homosexual is criminalized. It was considered a mental illness. So there's that connotation to it. So again, just using these words as adjectives, you know, a gay man, a lesbian woman or person, a bisexual person. The idea of sexual orientation being a preference or a choice, again, in 2020, the research is out there, that's not the case. It's an innate orientation. All sorts of words to describe transgender people. Transsexual is something that you'll see again a lot in older literature, but it has that surgical connotation to it. It has that, you know, someone has to have gone through a surgical procedure in order to be considered transsexual. And again, that's not the narrative that we want to embrace. So again, it's an adjective. It's transgender person, trans person. The idea of somebody being a biological man, you know, or born a woman, we hear that a lot. And no, when you think about it, they were born who they are. They haven't changed who they are. They were assigned this designation at birth. You know, someone external looked at them and said, okay, I see a penis, I see this, we're classifying this baby as a man or a boy, but that doesn't take into account their personal sense of their gender. So again, thinking of it more as an assigned gender or sex than someone was born a man and then became a woman. Like that's kind of a strange narrative. And so going along with that, thinking of things like people going through a sex change or a sex reassignment, we're going through gender affirmation surgeries or procedures or confirmation. So again, always thinking in terms of adjectives, not nouns, not verbs. So we had to set all that up to get into this section about discrimination and disparities. And again, I really want people to think about intersectionality, right? Like I'm focusing very much today on sexuality, sexual orientation, gender identity. But when we're getting to know our patients or our colleagues or our friends or whoever we're talking about, we have to make sure that we're understanding the whole picture. So everyone is situated in somewhere in these different areas, right? So understanding how those intersect, understanding the systems of power at play, the systems of privilege and oppression, and how those all have an impact on people's lives. And that's like a whole separate session on its own. So I just want to introduce the concept and make sure that we're keeping it in our minds as we go through this, because the experience of someone like me who is a white bisexual woman is very different from the experience of like a Black transgender man, right? So we have very different, and that's not even including a lot of the other characteristics. So again, keeping that in mind as we go through experience and discrimination, because in general, it's very difficult for LGBTQ people to find healthcare where we feel included and accepted. And this was a study from a few years ago where over half of the respondents who were lesbian, gay, bisexual had experienced one or more instances of healthcare discrimination. 70% of the transgender respondents. Like, I've been doing these for a long time. That number gets me every time. It's so large. And healthcare discrimination can look a lot of different ways, right? So it can, you can't even get in the door. You can't get the care that you need. You're refused care that you need. It can be, if you're in the door, refusal to touch, being blamed for what brought you there for your health status, harsh or abusive language, ranging all the way up to physical assault, right? And this slide is just population health 101. Populations who experience discrimination, stigma, trauma based on their identity, that's stressful. That leads to chronic and acute stress. That impacts your health. Your access to care impacts that. And that's what leads to the health disparities and inequities that we see. So again, there's no LGBTQ specific diseases or illnesses out there. There's nothing unique about our biology that makes us more susceptible to things. It's the culmination of the discrimination and the access to care. So I'm not going to go through this slide in depth. There are a lot of different health disparities in the LGBTQ community. I encourage you all to research, especially if you have specific populations that you're interested in working with. But really, you know, again, things that are related to stress, things that are related to preventative care, right? So a lot of these HIV, STIs, cancers, other things. They're not getting screened appropriately, right? If we can't even get in the door to get preventive care, we're going to see higher rates. So there's a lot to dive into here, but it's also important to look at the provider side, and which is why I love talking to students. I love talking to providers, because when I've done this for our existing departments at Keck, I usually ask people, you know, when you were in medical school, when you were in nursing school, whatever training that you had to go through to get to where you are, how much LGBTQ specific education did you get? And over the past 4 years, I can count the number of people who have raised their hands on both hands. People just are not getting taught about LGBTQ health. And then even if people are interested, they say, oh, this is a deficit, I need to learn more. There's limited research out there. We were not considered important to include in medical studies. It's expanding now. You will find more information out there, but like I did this for our internal medicine clinic. We had a physician who had a transgender male patient who has been on testosterone, you know, for 20, 30 years. Well, what's the cumulative effect on that, on your cardiovascular system, on your blood pressure, things like that? Those studies don't exist. There are no longitudinal studies that go back that long, because that was not a population considered worthy to study. So if research is your interest, I highly recommend pursuing LGBTQ health, because adding to the literature is so important. Training, you know, again, I'm so happy to be here, but people are not trained on how to have these conversations with patients. They know it's important, but if they're uncomfortable, they're just not going to bring it up. And then of course, having LGBTQ leaders in a healthcare setting. So I'll wrap up this section with this quote from Dr. Donald Berwick, which I love, because it really captures the essence of health disparities, right? So it's inequities in power, money, and resources give rise to inequities in daily life, which in turn lead to inequities in health. And he's quoting Sir Michael Marmot there. That is not politics, that is science. If you want to reduce health disparities, if you want to improve health, you have to reduce inequality. They're inextricably linked, so we have to think about it. And this is where I pause for a second, because that section is always really heavy. Like, that is not a fun section to talk about how things are terrible. And how, you know, how my community faces discrimination in healthcare. This is my favorite section, because then it's, okay, what can we do to create that welcoming, inclusive healthcare environment? And the section is called Cultural Competency Strategies, but it's really a trick to get us thinking about a cultural humility framework, because cultural competency is such a buzzword in healthcare, right? You know, it's like, okay, we understand that people are diverse. We understand that people have different cultural backgrounds. Let's learn about it and like check, check, check. It's a very check box related mindset. And so shifting to this cultural humility framework, which is really saying you're never going to know everything. In order to really be able to make a change and understand our patients, we have to be lifelong learners. So it's about making that commitment to a lifelong process of doing the work, to do self-reflection, self-critique, because we will always make mistakes. That is the one thing you can count on. But making that commitment to ensure that you're continually trying to understand different points of view, you know, respect different points of view, and have the commitment to want to change injustices that you see that our patients face. So part of how cultural humility framework can look like from a patient care perspective is really getting to know our patients. And this sounds very simple, but it's very hard to create the time and space to do this in a very busy practice. It's being able to look past someone's disease presentation and get to know them as a person, you know, really understand what are their needs, what's important to them, who's important to them, and what is their identity, you know, who are they as a person. And I think it's really important to think about all of the different ways that a patient moves through our system. So I'm going to use an example of a patient in our own Keck system that did not have a welcoming and affirming experience, because this is how we learn. So I think wherever you all end up practicing, whether it's, you know, fellowship, residency, permanent practice, understanding what that patient pathway looks like wherever you are is really important to understand where your gaps are. So the example that I'm going to use, this was a non-binary person who reached out, was looking for a physician to provide gender-affirming hormone therapy and used they, them pronouns, which we'll talk more about, but they were trying to find a doctor who would be welcoming. So again, it's like, how do people find out about this? You know, do they go on our website? Do they call our access center? So this person called our access center, was told, we don't do that here, which is not true, but our access center staff was not trained. They went to the website, couldn't find out a lot of information about, you know, what we do for trans health, found Keck Pride, contacted me, I connected them with a doctor, but while we were working on the back end to get something set up, they were like, oh, well, I'll just go online and make an appointment. Like, everybody loves computers and hates phones. What does our appointment request form look like? It has a mandatory field of gender with only 2 options, male or female. So this person reached back out to me, sent this screenshot, and was like, I literally cannot make an appointment request because there's no option for my gender. I don't want to do this. I don't want to come here. It's very clear that you do not want patients like me. So they hadn't even gotten in our door yet, and we're already putting up barriers to care and making them feel less welcome. This took months to get them comfortable and connected with the physician and make an appointment. So again, thinking, what do patients have to deal with when they come into the system? You know, it's not like you park and then you magically transport yourself into the office. You have to talk to concierge staff, parking attendants, front desk staff that are checking you in. There's 1,000 forms that you have to fill out to just tell us who you are. And then of course you're talking with a bunch of different people. You're talking with residents and fellows, you're talking with the MA, the nurse, etc. All of those interactions can be welcoming and affirming or not. And then I always think of this as like, I'm the Terminator. So when I go into a new space, it's like I scan, you know, like, and I'm looking for clues that this is going to be a welcoming space for me. So do I see marketing materials with my community? Do I see brochures about LGBTQ health? Do I see images? You know, do I see a healthcare equality index logo or sticker or something, a little rainbow? If I see any of those things, I feel a little better, and it's like a weight is off my shoulders. If I don't see those things, I'm still nervous. And so thinking about how we're communicating to our patients to make them feel welcome. So I'm going to talk about language a lot, and then at the end, a little bit about data and policies. And before we even get into language, we have to talk about what language reflects, right? So we have to talk about implicit bias and unconscious bias, and hopefully you're hearing more and more about this in your classes, in your learning, and just your everyday life, because we all have them. Like, literally our brains are set up to use stereotypes, to use implicit biases. We could not function through the day if we were not making snap judgments that we're not even aware of on a millisecond basis. But our implicit biases are just these things that we've internalized about a group separate from ourselves that is outside of our awareness, right? Like, we're not thinking about this all day, every day, but not doing the work. I think of it as like, you have a basement or an attic or a garage, you have all these old boxes in there. If you never take the time to actually like unpack them, shine a flashlight in and be like, where did this come from? Like, do I need this? Is this mine? How did this even get in here? If you're not taking the time to like kind of do a spring cleaning on your brain, on your biases, these build up and they unconsciously reinforce themselves, and they reinforce your own preferences. And they have a bigger impact on your behavior than actually your explicit biases. So you can say, oh, I believe that everybody should be treated equally. You know, I believe that women can be doctors. You could say these things, but if you haven't done the work to really understand what's behind them, that can come out in ways that you're not expecting. So really thinking about, what are your fundamental biases about gender? You know, what were you taught? What have you internalized? What's like hiding out in your brain basement that you haven't really taken the time to pick apart? And it's important to do this because there is research out there that healthcare provider biases can create poor access to service, poor quality of care, and poor health outcomes. And And I had to set that up because our language reflects what we think is normal and natural, right? Our language reflects our implicit biases. And so part of the way that we can challenge our biases is to be very thoughtful and intentional about what we're saying, and that includes using gender neutral terms. Because when we think about it, there's so many gendered words that we use on a regular basis that, again, we might not even think about. So using yes, sir, yes, ma'am. I was raised in Florida. I was raised in the South. You said yes, sir, yes, ma'am, or you got in trouble. That was my own unpacking that I had to do. You know, we say ladies and gentlemen, boys and girls. I don't know, it sounds like the circus. But for every gendered term, there's always a gender neutral option that we can use. So you're talking to a person, you know, a group of people, you work with individuals, you know, help welcome folks, you know, you're introducing yourself to everybody or everyone, children, kids, and families, because we have very gendered ideas of what makes up a family. But again, for every word, you know, instead of asking somebody if they have a mother or father, or what about their mother and father, asking about parents or guardians, or thinking about it in that term. Instead of sons and daughters, asking about children or kids, sisters, brothers, siblings. There's niece, nephew, nibblings, which I love. But again, asking people in very gender neutral terms to let them know who's in their life. And I like to pause here for this implicit bias check, because looking at these little images of people on the screen, what flashed into your head? What were you thinking? Were you thinking, oh, that's two men and a baby? That's a woman with a baby in a stroller. That's a gay couple with a child perched on their arm like a parrot. Like that one cracks me up. That's why I had to include it. But I had to do that myself when I was picking these, because I was like, I don't know these people. I'm making a judgment based on things that don't actually reflect gender at all. And so I had to be like, look, I don't know any of these people. I think they might all go to the same barber, but that's the extent of my knowledge. I don't know who they are. I don't know how they're related to each other, and I don't know their genders or their terms. So I had to do that even as I was creating this presentation, right? You have to constantly think like, wait, how are my biases showing up? What am I thinking about people that I don't know? Relationships. We love to ask patients about relationships, and it's important to know, but avoiding those assumptions. Again, just because you found out someone's sexual orientation or their gender identity, you cannot assume what their relationships with other people or the genders of their partners are going to be, right? So asking about a partner, a significant other, a spouse, you know, are you in a relationship, something like that. And again, implicit bias check. When you saw these little people, what were you thinking about how they were related? And just kind of challenging yourself, what words could you use instead of the gendered ones that might pop into your mind? And this is what I love to bring up, because it's so hard sometimes to think about how we can find out this information instead of asking somebody, oh, you know, who is this? Like, who do you have with you today? Being a patient is very stressful, right? And especially being an LGBTQ patient, because we're anticipating that discrimination. So instead of having to be, you know, doing the mental math of like, wait, this person just made an assumption. Should I combat that? Am I in a safe space? Am I going to get treated differently? Putting the power into the patient's hands so that they can decide what they want to tell us is really empowering. And I actually made this its own slide after a presentation that I did with our cystic fibrosis clinic. I will call them out. We were talking about relationships, and one of the nurses said, I need to tattoo this on my wrist because I put my foot in my mouth all the time. I just this week had a patient come in, so cystic fibrosis, younger patient population. This was a younger woman with an older man. And the nurse says, oh, is this your grandpa? And the patient had to say, no, this is my boyfriend. So immediately that's putting this person on the defensive, right? Of like, oh, this nurse already made an assumption about me. I already have to like say something back. If the nurse had just said, who do you have with you today? This person could have thought, you know, oh, this is my boyfriend, this is my grandpa, like this is some dude I met in the lobby and asked him to accompany me. Like whatever the situation is, you don't know until you give them the space to tell you. So thinking about what types of questions are we asking people? What open-ended questions can we create, and making them gender neutral and asking them of everybody, right? So these are just some examples of some open-ended gender neutral questions. It looks like this poor patient is being barraged by the healthcare worker, but making sure that, again, you're not making assumptions of who needs to be asked what, because then inevitably people will fall through the cracks. And of course, name and pronouns, right? Everyone has a name, everyone has a pronoun. That's why I wanted everyone to put their name and pronoun in their Zoom. But making sure that you're using pronouns that you found out. So otherwise, stick to gender neutral language. I won't go into a lot about this. Note that you can't always trust the paperwork or the chart, right? Going back to that, not everybody can get their documents changed. Not everybody can have an ID or insurance card that reflects their name and gender identity, so still making sure that you're asking. I do want to focus on the singular they pronoun because I love it. I want everybody to embrace it. I think it can be so helpful to get comfortable with it. I mean, number one, because people use they and them as their personal gender pronouns, right? So not using she or he, but using they, them, theirs, or using like a hybrid she, they, or something like that. So getting comfortable so that when you encounter somebody who uses they, them pronouns, you're not like, they, like, you know, that it sounds more natural. Unknown gender, you have, again, you haven't met someone, you don't know them. So instead of assuming or saying he or she, which is like wordy and uncomfortable, just using they. So think about, again, like if you have a practice, I show up as a new patient, well, pretend you've never met me before, pretend I didn't share my pronouns at the very beginning. You don't know me, you might be making assumptions, but instead of doing that, when you're communicating with your colleagues to say, oh, we have a new patient, Lindsay, they're in the waiting room, you know, they're here for whatever, you know, a persistent cough. I'm gonna bring them back to the exam room, get them all set up, and I'll let you know when they're ready. Like doesn't sound awkward. You've avoided misgendering me. You've avoided unintentionally, you know, doing a microaggression against me, which we'll talk about. And then once you meet me, you can find out my pronouns and go from there. Generic examples in healthcare. We love saying doctors as he and nurses as she. Whenever we hear like just a generic example, it's usually very gendered, right? So instead of saying like, oh, when you reach out to your primary care physician, make sure you tell him that you had this test, make sure you tell them. Making it a they, using they instead of he or she, and accidentally reinforcing ideas that you probably don't believe in, right? Like, again, I'm going to assume everybody in school in 2020 is not like, only men can be doctors. I'm going to assume that. I really hope that's true. But it's just important, practice, practice, practice. So practicing with your colleagues, practicing with your friends, practicing with your cat, practice talking about the person who walks their dog outside of your yard, you know, whatever it is, just really trying to challenge your thoughts and like using gender neutral language, using the singular they. And it is in most electronic medical record systems now, which is great. Microaggressions. I'm gonna kind of go through this a little quickly just so we can have some time at the end, but microaggressions are so important because, again, I feel like with the healthcare discrimination slide, again, my assumption is that most people listening to this are thinking, I would never physically assault a patient, you know, I would never kick a patient out or be verbally abusive toward them. But microaggressions are these little things that we don't even think about. They're from those implicit biases, right? Those unconscious biases that actually have a harmful or discriminatory implication. And they reinforce our worldviews. Again, they reinforce these things that we have buried in our brain basement that we haven't really unpacked of, like, what do we consider superior or desirable or undesirable or normal or abnormal? So microaggressions can show up in a lot of different ways. Again, I'm not going to read through these one by one. You will have the PDF of this to reference, and there's a ton of more examples out there. But they're all of the ways that invalidate somebody's identity or their experiences. And the thing about microaggressions that I think a lot of people have to be conscious about is they can come from a good place, right? They can look like compliments. They can look like somebody had good intentions in communicating, you know, like this top middle one of like, oh, I never would have known you were trans. Like, you're so pretty, or like, you look just like a real man. Like, that's a weird Pinocchio way of thinking about it. But like, that person is probably coming from a nice place, but it has a harmful effect, and it has a way of saying, well, here's the way to do this, and there's a bad way to be. And microaggressions are a health issue. That's why we have to be very conscientious and thoughtful, because think about it like you're wearing glasses, right? So glasses help you see. You get one scratch on your lens, one microaggression, whatever. It's annoying. You can get through your day. But the more microaggressions that you face, and again, I'm really focusing here on LGBTQ microaggressions, again, thinking of racial microaggressions, size microaggressions, class, all of that, the more and more scratches you get on your lenses, at some point you literally can't see where you're going. You can't function. You can't live your life the way that you were when your glasses were fine. And the example that I use sometimes, you know, so I've worked at Keck for almost 12 years. When I started, I don't even remember how this came up, but with a colleague, I was like, oh yeah, I'm bisexual. And she was like, no, you're not. I was like, so she'd already invalidated my identity. And I was like, no, I promise you I am. Like, I assure you I am. And she was like, well, that's not real. So that idea that bisexuality is just people who are confused, you know, haven't made a choice, are deluding themselves, that double edge of invalidating and, you know, making me sound like some kind of magical creature, it didn't affect my relationship with her. We still have a great working relationship. I kind of was like, I know how to interact with you now. But I bring this up as a microaggression example because this happened 12, 11 years ago. I guarantee you she has no memory of this. I have never forgotten it. And that was one time. So think about the cumulative effects of what people experience on a regular basis and how that can have an impact. And of course, you will make a mistake, right? We talked about that. Everybody is going to make a mistake. The bigger mistake would be not to discuss sexual orientation or gender identity because you're afraid of making a mistake and upsetting somebody. Again, practice. It won't be perfect. You'll get more comfortable knowing that people are coming in with these past experiences or potential, you know, maybe they have a friend who had a bad experience. People might be more bristly. So just giving a thoughtful apology. I'm going to go through this real fast. Again, just as your students, thinking about when you go into your practices or when you go into a new place, understanding all the different ways that patients have to tell us who they are and how inclusive they are. Making sure that you familiarize yourself with the capabilities of the electronic medical record. Cerner and Epic are the big ones. They all have capabilities to record gender identity and birth sex separately. We just added people's pronouns and their preferred name, like a nickname, in 2020. And we have the capability to record gender identity and sexual orientation in more detail. So again, just understanding the capability and being able to use it. Understanding the policies that are there around non-discrimination, how inclusive are they? Do they include gender identity? Does your facility have an inclusive restroom access policy of basically saying you use the restroom based on your gender identity, not anything else? And how is that communicated? And then if your facility has policies for transgender patients specifically, understanding those and how to implement that. Again, we're not creating any of this from scratch. Most healthcare organizations are using guidelines put forth by CMS, by Joint Commission. A lot of great national organizations have resources. Again, I highly recommend you seek them out and read through them. I always end with this real patient letter because again, this can get very cultural competency mode, right? Where you're like, okay, I have to use these words and check my policies and do this, like check, 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 but bringing it back to that patient experience. So this was a patient of our Verdugo Hill, so our community hospital. Again, not going to read this verbatim, but he was a transgender man, seizure disorder, in and out of hospitals, had very bad experiences and started being very afraid to get care, especially after he started transitioning. Came to our emergency room where I've done trainings and said the nurses were sensitive. They used my pronouns. They treated me with dignity. I felt safe when I was there. And I've been reading this letter since May of 2018, so over 2 years, and I get chills every time because that's why we're in healthcare, right? We want people to feel safe and we want them to feel dignified. And so just for him to have that experience of saying it can make such a difference to myself, to someone like myself. And so thinking about, you know, when we think about gender neutral language and we think about pronouns, and sometimes it can be like, what is the big deal? You know, why am I focusing on this? And because in some situations, it could literally mean the difference between life or death for people. And so things that you can do literally starting today is starting to do that work of looking into your own assumptions and stereotypes and, like, again, unpacking those boxes, bringing that flashlight and being like, wait a second, where did that come from? Is this mine? Do I still want this? And if I don't want it, how can I challenge it? Because you can't just throw it away, I wish. But part of the way that you can challenge things is by being intentional and using that inclusive gender neutral language. Of course, always respecting LGBTQ patient privacy, trying to give patients the power to tell us who they are, of course, treating everyone with balance and respect, and the cultural humility framework of seeking out continuous learning, seeking out the research that's out there. And I know this was a lot to get through in such a short period of time. I welcome you to reach out to me with any questions if you're looking for specific resources. We have a very rudimentary LGBTQ health webpage on CAC Medicine. We're working on expanding it, but I would love, I know we don't have a ton of time left, but I would love to open it up for questions. I'm gonna stop sharing just so we can bring this all up. Ooh. Oh, there was a question. How is gender alignment viewed when referring to surgical procedures? I think that is a great question because it's really thinking the whatever the procedure is, right? And again, there's so many different types of surgical specialties for one thing, and then procedures within a specialty. And it's thinking about the surgery as aligning that person's body to better match their gender identity and better match how they see themselves. So that's how it's this alignment process where you're not reassigning things, you're just helping to create that body that better fits how they feel, if that makes sense.
I have a question.
Yes.
Thank you so much for being here. This has been super wonderful. Often medical students are taught when we take a sexual history to ask, do you have sex with men or women? That's obviously not in line with anything that we've learned today. I was wondering if you've come across better ways to ask that question and ones that are less clunky.
Yeah, I think, again, that's such an interesting question as well. And it gets into this idea of scripting and training. I think part of it depends on the functionality of the system that you're putting the data into, right? So first, knowing like what you can check off or fill out. I've seen, you know, do you have sex with men, women, or both? Like, who are you, you know, who do you have sex with? Like, what are your partners like? Because again, you have to keep in mind, even if, and I've had this experience in the doctor's office where, you know, I'm saying, well, my current partner is a man. And then they're saying, oh, well, you have to go on birth control. And I'm like, no, there's no penises or sperm involved. My partner is a trans man. But if they didn't create that space for me to tell them, and if I weren't just like, again, at this point in my life, I'm like, I don't care. I will make sure that you're giving me the healthcare that I need. But if they just heard man and didn't find out anything else about my partner, then they're missing a huge clue. So I think it's, again, just trying to ask about like, what are the genders of your partners? If, again, depending on what information that you need, like, can you describe the body parts that are involved? Getting to know them again, because I was like, no, I don't need birth control. And of course, as a primary care provider, they're like, no, that's a very important part of women's health. And it is, but it has to be personalized and customized, and they have to make the space to really find out about me and my needs.
Thank you.
I hope that helps.
No, it really, really does. Thank you so much.
I know I know it's always a lot to take in. You know, it's like your brain is a sponge, and then also Zoom fatigue as well. And that's why, you know, again, Therese can send out the PDFs, because especially I feel my experiences, especially when we're talking about gender and transgender, gender diverse patients, thinking about sexual orientation, again, in 2020, I feel like most people are like, okay, I can understand a person who is attracted to or has other gender partners, but having to think about like, oh, everything I learned about gender from my parents is wrong. You know, I mean, that can be a lot to unpack and think about, of saying, wait a second, literally everything that I've been taught growing up, I never got the full picture. And how do I unpack these ideas that you're taught in medical school, right? Like I'm not a clinician, have not gone through any kind of training. My assumption, again, is things get very gendered when you're thinking about patient care, and like how to question that at every sense of saying, wait a second, if we're talking about this patient population, who are we actually talking about?
I have a question. It might be out of scope, but do you kind of know the steps of how future physicians or current physicians can get into gender affirming care and how they can be involved? I'm not sure if there's like a specialty or if you have any knowledge about that.
I don't think there's like a formal specialty. There are a lot of trainings that people can go through. There's actually, oh my God, what is it called? It's through, if you look up like transgender care conference Fenway, I think, so there's like, and everything's virtual now. So there's a huge 2 to 3 day conference where there's different trainings that different specialties can go through. I think it's about understanding what resources are out there. So there's, especially for transgender health, there's WPATH, which is like sometimes controversial. It's a very gatekeeper model. It's trying to shift a little bit, but it has very specific, detailed information about transgender care that's very clinical. Again, so like I'm not that familiar because it goes very into like surgeries and hormone dosages, and I'm like, cool, I'm never going to provide that. So there's WPATH, there's conferences that people can attend, there's San Francisco, the health system up in San Francisco that has, again, like very detailed information. I think it's about learning as much as you can, as much as what's out there, because what we're seeing, especially in KEC, in trying to understand what our physicians can provide, so many of them never had formal training. They're just learning it as they go along. They're just trying to find what's out there, connect with other providers, because it has been such a historically left behind population, you know. So again, there's more resources, but it can be difficult. But especially as students, I know a lot of the conferences have student rates, things like that. And if you're, again, if you have the muscle to ask for sponsorships, or if you're in practices of saying, this is training that really interests me, can I attend this conference? Or shadow a provider that's doing it, I think that's helpful, because there's such a huge demand for trans health. And so even providers that are like, I've done a lot of self-education, patients are like, cool, as long as you're willing to do the research and treat me, we can get through this together. Yes, Fenway. Again, Fenway has amazing online webinars. I highly, highly, highly recommend them. Again, they go into very clinical detail, some of them. They have a lot of very population-based webinars. You can earn continuing education credits or clinical credits. I don't know about clinical credits, definitely education credits. But yes, I very highly recommend spending some time on their website. Great. I mean, I know we're a little over. I'm more than happy to stay on for a few more minutes if people have questions, but this has been such a pleasure. Again, practice those terms. Talk to your cat, talk to your dog.
Is there any, so before I cut it off, is there anyone else with a question? No. Okay, well.
I have one quick question. I know you mentioned briefly ways that providers can demonstrate that they're a safe space. Are there favorite ones that you have seen? I was wondering about like looking into prefer or gender pronoun pins or things like that for my white coat.
Yeah, I mean, I've definitely seen people wearing pins or buttons that say their pronouns. Depending on where you're practicing, if you can have something on your badge, like a little sticker or a like a badge underhang. I think having visual cues in your space, if you are part of an organization that participates in the Healthcare Quality Index and has that logo, have that logo visible, even just having like a little rainbow flag or something, or even, again, depending on where you are, what the policy is, if you're having cues of we don't discriminate against sexual orientation or gender identity, along with all of the other categories, right? Just having things that people can look at. There are downloadable like LGBTQ health brochures. Again, everything's virtual now, so it's not like, I know we took away all the brochures in our clinic, so that might be like an outmoded way to communicate now. But I think having any kind of information available, so even if you're creating a website about your practice, you know, having a link to other organizations, just saying that you are familiar with LGBTQ health would be a sign. Like as a patient, if I saw that on my doctor's website, I'd be like, whoa. I mean, my doctor's great, but if I were finding a new doctor. Yes. Artwork, magazines, anything. Again, like I said, I'm like a Terminator. If it's there, I will find it. You don't have to like make it super obvious.
Thank you so much.
Of course, pleasure. Yes, again, if anyone has
Thank you so much for Lindsay coming over to doing this workshop, and thank you for everyone else for coming in and doing this workshop with us. I think that's a wrap.
Yeah, I mean, it's kind of like a plug for myself. I have more trainings that are on like diving in deeper into implicit bias and intersectionality, diving into like more specifics on like, especially healthcare providers of like, how do I be an ally, an LGBTQ ally in healthcare? Yeah, more trainings on like population-based health, like bisexual health and trans health. So I'm always happy to come back. But it's been my pleasure. So thank you all. And I hope you have a great rest of your day wherever you are. And stay safe.
Thank you. Bye, everyone. Stay safe. Nice seeing y'all.